Welcome to this webinar on Behçet disease. We have, I guess, quite a mixed population that's online, including maybe both patients and physicians. We're going to talk about Behçet disease. It might be sometimes, if there are mostly patients listening, difficult to understand all that I'm trying to tell you, but at the end, there will be the possibility to ask questions. But before I will talk about Behçet disease, I guess Emna is wanting to tell you something about Immunate, because this meeting is also sponsored by Immunate. Emna?
Yes, thank you, Paul, very much for accepting the invitation and to share your knowledge about the Behçet disease. So this webinar is organized by Immunate in collaboration with the FMF and AIDS Global Association. And I will just give you some words small words about what is Immunate. So Immunate, it's for Immunome Consortium for Autoinflammatory Disorders. So it is a European clinical project. It's on 5 years with 25 partners and on 12 different countries. Next, please, Paul. So what is the main goal of this project? It is to provide a novel diagnostic classification of systemic autoinflammatory disorders. So we are working on many disorders. So we are on rare disorders. Among these diseases, we are working on Behçet disease, and we want. So the first aim is to provide a novel diagnostic classification on these different disorders. So just to explain what is the strategy and what is the plan of the project, please next, Paul. So we are actually building a cohort of participants. So we are collecting samples and clinical information from the patients and from the healthy controls. These samples are actually analyzed by different research laboratories all over Europe. So they are working on DNA of the samples, or on RNA, on proteins, on microbiota, on different molecules, just to understand what is behind this disease and what is happening in these samples, to better understand these rare diseases. So all this information and all this analysis will be combined to be analyzed by computational analysis, so using machine learning technologies. And the aim is to find the common signatures, or to define biomarkers to each disorder, and to be able to design an algorithm to guide the diagnosis. So actually we are still building this cohort, and we have more than 360 patients. So it's already a really good number of patients and of healthy controls. And it is thanks to our recruiting sites. So we have 34 clinical centers all over Europe that are recruiting and actively including patients. So we have, as you can see, many clinical centers in France, in Greece, one center in Netherlands. So Professor Van Del is the principal investigator in this site. We have centers in Spain, in Slovenia, UK, Belgium, Germany, Turkey, Italy, and Switzerland. So we still need patients to have really powerful analyses and powerful results. So please next, Paul. If you are a patient and you are interested in the study and you want to participate, you can contact me directly via this email address. So maybe it's too late, but I am the clinical project manager. Sorry, I forgot to present myself. I'm the clinical project manager of the Immunate project. So if you are interested, you can contact me directly on via this email address. If you just want to know a little bit more about the project and to understand more the goals, you can directly connect on our website. Can you see here? And if you just want to know what are the updates, what are the news, you can follow us on Twitter. And thank you. That's all for me. Paul, the floor is yours for the presentation.
Yes, thank you very much. I'm Paul van Dalen. I'm an internist and an allergist clinical immunologist, and I made this presentation together with Jan van Laar, and he's the president of the last international conference on Behçet's disease, which was held in Rotterdam. I believe it was in 2020 or 2019. What is Behçet? Behçet is a disease which was first described in 1936 by Hulusi Behçet, which was a dermatologist from Turkey. He described a small group of patients that presented with oral ulcers and genital ulcers. And these patients also had involvement of the eye. They had a uveitis. And so after this description, they termed this disease Behçet's disease. Although if you're living in a different country, like in Greece, it might also be called Adamantiaris Behçet's disease. So the name of the disease is different in different countries. So the disease is in fact characterized by oral ulcers. If you do not have oral ulcers, well, then you're probably not having a Behçet's disease. But apart from oral ulcers, many patients also get genital ulcers, as you can see on this slide. Over here, you see on the right-hand side the oral ulcers, which look a lot like afts, and also the genital ulcers here. And apart from that, there is also the painful pustules that can be located anywhere on the skin. But it's a disease that is not only characterized by these ulcers. There are many other symptoms that these patients can also present with. So here is in more detail also the ulcers that you can see, or the sores that you can see in the mouth. Here you see a tongue with the ulcers on the side, which is also to be recognized that these ulcers are very painful. Because there are other diseases that can also present with oral ulcers and genital ulcers, like, for instance, syphilis, which is a transmittable disease. These patients with syphilis do have ulcers, but they do not hurt. They are not painful. And here are again, but I shortly skip this slide, the genital ulcers that can be found. But there are also other lesions that can be found on the skin of patients with Behçet's disease. And a noticeable skin manifestation is what we call erythema nodosum, as you can see on this slide. On the legs of this lady, you see these red and they're also a bit elevated spots, which can also be painful. We call that erythema nodosum. These spots can also be seen in other diseases, like for instance Crohn's disease or in tuberculosis. And the trouble is that as it is also seen in Crohn's disease, some patients with Behçet's disease are misdiagnosed, because you can also have in Behçet's disease ulcers within the gastrointestinal tract. So then it resembles Crohn's disease quite a lot. That sometimes can be a problem, because although the treatment overlaps between Behçet's disease and Crohn's disease, it's not completely the same. Now, another hallmark of Behçet's disease is the positive pathogen testing. And that the positive pathogen testing is a test in which a patient that is suspected of having Behçet's disease gets several injections with a sterile needle, usually in the lower arm. And after 1 or 2 days, you will look at the spots in which the puncture was done. And then there will be pustules visible in patients that have a positive pathogen testing. as you can see on the slide on the right-hand side. So there were 5 or 6 spots injected with the same needle. And after 2 days, you see clearly these pustules, which is something that is hardly ever seen in any other disease. So it's a very strong argument that this patient might be suffering from Behçet's disease. Now, the pathogen testing has become less sensitive during the last years, and that's because the injection needles that have been used became more sharp, and to be more sensitive, actually the needle used should be a bit blunt, and you should also reuse the needle for the puncturing for all the 6 punctures that you are giving to the patient. Behçet's disease is a disease in which all patients have oral ulcers, many patients have genital ulcers, many patients have other skin involvement, but it's a disease that is not limited to the skin and the mucous membranes. Unfortunately, also many patients do have, for instance, involvement of the joints, and some present with pain in their joints, so arthralgia. Some will present with arthritis. But also a very common involvement is involvement of the eye. Up to 50% of patients with Behçet's disease will have a uveitis, which is an inflammation, a sight-threatening inflammation of the eye, so you can get blind by this inflammation. Some patients have neurologic involvement, like stroke-like episodes, for instance. Also very common, or relatively common, is gastrointestinal tract involvement, a bit resembling Crohn's disease, so inflammation of the intestines, in which patients present with, for instance, bloody stool, stomach ache, weight loss, all symptoms of involvement of the gastrointestinal tract. And also a very severe complication is involvement of the vessels. And the vessels that are involved in Behçet's disease are both the arteries and the venous system, which is very rare in other diseases. I know of no other disease in which you get involvement of both the arteries and the venous system. I have a picture showing involvement of the vascular tract in patients with Behçet's disease. Now here is a picture what you can see in a patient with Behçet's disease that has eye involvement. If you have eye involvement, it's the involvement of the vascular layer within the eye. And if you have eye involvement, you can have eye involvement in the front part of your eye, which is called an anterior uveitis, which can be very painful. And patients can have blurry vision. But for an anterior uveitis to lead to blindness, that's not very common. But unfortunately, many patients with Behçet's disease also have involvement of the more deep layers in the eye, so which we call then a posterior uveitis. And this slide is an example of a posterior uveitis. It's an inflammation in the back of the eye. And what you can see here is the retina. And in this retina, you see here these red spots, which is a bleeding within the eye. And you can understand that if you have a bleeding in the eye, this bleeding in the eye will ultimately lead to blinding. And if a patient presents having Behçet's with blurry vision, we should act fast to prevent this patient from getting blind. And there is therapy for this uveitis. This is another example of another manifestation of a patient with Behçet's disease. What you see here is a CT scan, and in this CT scan you also see all these blood vessels. This is abnormal. You should not have all these blood vessels. This is a manifestation due to inflammation of the blood vessels. And as I mentioned, you can have involvement of the veins, and you can have involvement of the arteries. This is involvement of the veins in this patient. But what we also can see, and which is also very uncommon in other disorders, is a vasculitis of the pulmonary arteries, which leads to, for instance, shortness of breath, coughing up blood, also a very severe manifestation of Behçet's disease. We not encounter it frequently, so we see about 1 or 2 patients a year with this kind of involvement in Behçet's disease, but you will have to treat these patients aggressively because it's a potential lethal complication of Behçet's disease. Luckily, most patients do present with mainly the oral and the genital ulcers, which are not life-threatening, but you can understand that as these ulcers are painful, the patients do have a lot of loss of quality of life. Now, how do we make a diagnosis of Behçet's disease? When do we have to think of the diagnosis, and how will we make sure that a patient does have this disease? Well, over the years, there have been developed criteria for Behçet's disease, and as I already mentioned, one of the most important things to realize is that the patients believed to be suffering from Behçet's disease do have to have aphthous ulceration in the mouth, and preferably these ulcers should have been seen by the physician that is treating the patients. So, and apart from the recurrent oral ulcerations, you also check whether there are genital involvement, so genital ulceration, whether there's eye lesions, so uveitis, that being either anterior or posterior, but severe inflammation of the eye, skin lesions, and a positive pathogen testing. And in this diagnostic criteria box, you need at least 3 of the symptoms to make a diagnosis. So you need to have recurrent oral ulcerations, but apart from that, you need either recurrent genital ulcerations and eye lesions, or recurrent genital ulcerations and skin lesions, or a positive pathogen test and skin lesions. So you come up with 3 symptoms, and then you can make the diagnosis. There is also another way to make a diagnosis, although this one is probably still the most used way to get to the diagnosis of Behçet's disease, and that's by using the ICBD criteria. These are the criteria of the International Behçet's Disease Association, and they weigh certain symptoms. So ocular lesions again are the eye lesions, get 2 points. Genital aphthosis 2 points, oral aphthosis 2 points, skin lesions 1 point, neurologic manifestations 1 point, vascular manifestations 1 point, positive pathogen test 1 point. And if you have several of these signs and or symptoms, and you add these signs and symptoms up, and you get to a total calculation of at least 4, then you can also say, well, it must be the Behçet's disease. So if you, as you can see in this patient, if someone is presenting with genital aphthosis and oral aphthosis, he will have 4 points. Then he will have the diagnosis, which is a bit different from the formal earlier criteria, in which you needed a 3rd manifestation. So using this criteria, the sensitivity, the likelihood of finding a patient with Behçet's disease is higher. But some of these patients actually will not have Behçet's disease, so specificity is somewhat lower in using this ICBD criteria. Behçet's disease is not a very common disease. It's, in fact, it's rather rare, but it's dependent on where you live. It's also called the Silk Road disease, because if you look in what countries the prevalence of Behçet's disease is high, then you will see that it's especially high in the countries that were in the past along the Silk Road. So it's high, for instance, in China and Korea. It's very high, the prevalence in Turkey. And in time, it has spread further over the world, but still the prevalence is most high in the countries that are located along these red lines. So here is a more clear picture is showing the high prevalences in the different countries. So as I already mentioned, high in China, also high in Korea and Japan, in Iran, Iraq, but the highest prevalence overall in Turkey. And if you look at the Western countries, like in the Netherlands, prevalence is much lower. And most patients that are seen in Western countries like the Netherlands and Germany and Belgium are originally from Turkish descent. And also you can see that in the USA, the prevalence is also relatively low. And what is striking is that the countries in which the prevalence is highest are also the countries in which the people live that have a genotype which you call HLA-B51. HLA-B51 is sometimes also used as a diagnostic criterion, but it should not be used like a diagnostic criterion. You should stick to the criteria that I just mentioned, that having positive pathogen testing, uveitis, oral and genital ulceration. That are the tests you should use to make a diagnosis. So high prevalence in countries that have high prevalence of HLA-B51, and in other countries in which there is a low prevalence of HLA-B51, the prevalence of Behçet's disease is also a bit lower. So here are some data from our own center in which we looked at the prevalence of Behçet's disease. And what you can see is that in our center, most patients presented with Behçet's disease are from Turkish descent. We have quite some patients from Morocco, but there are patients that are originally from the Netherlands, so Dutch Caucasians that do suffer from Behçet's disease. But per 100,000 patients, the prevalence is much lower than it is in patients from Turkish descent. Behçet's disease is a rare disease, but what kind of disease is it? It's a disease that is studied in immunate, so that means it's probably a disease that is autoinflammatory in origin, but is genetics also playing a role? And the answer is probably yes. Genetics does play a role. Here are some genes that have been studied, whether they have association with Behçet's disease. And for all these genes that are located on this slide, there has been an association found. And if you look at the proteins that these genes make, then you see that these genes are involved within the immune system. So they're involved within the innate immune system, which is the immune system that is also seen, for instance, in lower animals like sponges and mollusks. They have part of their immune system which is similar to the immune system in humans. So these genes are involved in the innate immune system, but we have also in our immune system the so-called adaptive immune system, that are the T cells and the B cells and the antibodies. And there are also genes involved that have a link to the adaptive immune system. But what is most important to notice from this slide is that in patients with Behçet's disease, some genetic alterations, some mutations will lead to a higher risk of getting Behçet's disease. So genetics, yes, they play a role. Yes, it's autoinflammatory in origin, but as I already mentioned, some patients with Behçet's disease also have involvement of the vessels, that being the arterial vessels, but also the veins. So you could also say, well, is Behçet's disease then probably a vasculitis in origin? And the answer would be, I believe, yes. In a way, it's also a vasculitis. So it's genetic, yes. In a way, it's a vasculitis, yes. In a way, it's autoinflammatory. In a way, yes. So what is happening in Behçet's disease, or what we should call it actually, is an immune-mediated disorder in which there is a genetic factor. So there are people that have a mutation in some gene, which makes them more likely to develop the Behçet's disease, although not all patients with the same mutation will develop this disease. You will need a trigger, and that trigger can be infections. The trigger can be trauma or smoking or stress or allergy or foods. So if you have a genetic predisposition and you have this trigger, then you will get an immune response. Your immune system will get activated.
Đấy.
Response will lead to tissue damage and ultimately to Behçet's disease. So that's the concept. It's important to know something about the pathophysiology, because if you have understanding of the pathophysiology of Behçet's disease, you can also... I'm sorry. Okay. I hear some background noise. Okay, I believe.
Can you please turn off your mic for the people that are listening, please? Thank you.
It's important to know something about the pathophysiology of Behçet's disease, because if you understand the pathophysiology, you can also try to find new treatments. Genetics you probably can't alter, but you can do something, for instance, on cytokines, on T cells and B cells, all cells and cytokines or proteins that are involved in this disease. So cytokines that have been involved, for those that are not doctors, cytokines are proteins that are produced by immune cells, and by producing these cytokines, these immune cells are able to communicate with each other. So we communicate by speech. I tell you something, and I hope you understand what I'm trying to say. Immune cells do the same. They also communicate with each other, and one cell produces a cytokine, which then by the blood goes to another cell, and then that other cell knows what to do. And these cytokines that are produced in Behçet's disease are overproduced in Behçet's disease. So there's more than there should be produced, are IL-6, IL-8, IL-12, so a number of cytokines. And what is also important to note is that there are also not only cytokines, so proteins involved, there's also cells that are involved in the immune response, the over-exaggerated immune response, and that are T cells and B cells. So B cells, for instance, are the cells that are responsible for the production of antibodies. We had the COVID-19 epidemic, and we all got a vaccination, and we are vaccinated to produce antibodies against this virus. But you can also make antibodies against your own body, and that is called autoantibodies. And of course, you should not have autoantibodies, because that will lead to inflammation and destruction of your own cells. And we see actually quite a lot of autoantibodies in patients with Behçet's disease, if you look carefully. And what's also important to notice is that it's not only the immune cells that are involved in Behçet's disease, it's also the endothelial cells, and the endothelial cells that are the cells that are the lining up of the blood vessels. Now, for the patients, most important probably is not so much knowing the pathophysiology or knowing how to make a diagnosis, but what is for patients important is how can I treat my disease. And in Behçet's disease, treatment differs strikingly depending on what organ is involved. So you can understand that if you have mainly oral ulcers or genital ulcers, which are not life-threatening, although they cause a lot of pain and discomfort, treatment will be less aggressive than a patient that have, for instance, neurologic involvement, that have a stroke-like episode, a patient that have blinding eye involvement, or patients that have severe involvement of the vessels. So if you have mild disease, relatively mild disease, you will treat relatively mild. So for oral and genital sores, for oral and genital ulcers, often patients are treated just locally. What you then do is most of the time apply local corticosteroids, local prednisone. Prednisone is an immune suppressive drug, which has an effect on T cells, which has an effect on B cells, and which also has an effect on cytokines. So by applying local corticosteroids, you can imagine that you will be treating the local inflammation leading to the ulcers. Another treatment, also often used, especially for the oral ulcers, is colchicine. And colchicine is a drug that is developed not for the treatment of Behçet's disease, but it's used for especially the treatment of gout. gout is a form of arthritis, which can be very painful. But colchicine also is a relatively effective treatment if patients are only presenting with oral ulceration. Doesn't work in everybody, but in many patients it does. And colchicine is relatively well tolerated. If you use not that high doses, it does not have very many side effects. Different from, for instance, other treatments that are used also for the oral and genital source, like Dapsone, which can lead to, for instance, also a severe anemia in some patients, or thalidomide, which is a drug that has a bad name because in the past it was used in pregnant women and they gave birth to children without arms or legs. Thalidomide, although it has a bad name, and for good reasons, has a bad name, it is effective in a group of patients presenting with severe ulceration that do not respond to other treatment. And so if you're suffering a lot from these ulcers, then it might be something that could be prescribed by your physician. Pentoxifillin is also on this slide. Pentoxifillin is not a very effective drug, but it's sometimes in a very small group of patients with oral ulceration and general ulceration effective, and it does have very little side effects. So because it has very little side effects, it's sometimes tried, although it's not very effective. But not all patients have only oral or genital involvement. There are patients that present with eye involvement, vascular involvement, neurologic involvement, gastrointestinal tract involvement, and these patients will need more aggressive, more severe treatment. And in these patients, you will not give only local application of corticosteroids. In these patients, you usually start also with oral steroids, with oral prednisone. And depending on the severity of the involvement, you will get either low or even very high dose of oral steroids. Another way to treat patients is also with medication that is often used in patients with either rheumatoid arthritis or in patients with, for instance, a kidney transplantation, like cyclosporin or azathioprine or mycophenolate. These are used in patients with uveitis, with involvement of the brain, and are effective, but do also have many side effects. And more recently, we noticed that also many patients do respond very well to biological drugs like anti-TNF. And anti-TNF is a drug which is also prescribed to patients with rheumatoid arthritis, but it's also a drug that is given to patients with, for instance, Crohn's disease, which is an inflammatory disorder of the intestinal tract. And as I already mentioned previously, some of the patients with Behçet disease do also have involvement of the gastrointestinal tract. So in gastrointestinal tract involvement, or in eye involvement, or even in brain involvement, anti-TNF is an effective drug in many patients, and also with limited side effects. It's not that there's no side effect. There is no drug that does not have a side effect. So also anti-TNF does have side effects. It will increase the risk of getting infections, but usually as compared to the more older drugs, or even compared to prednisone, anti-TNF is actually reasonably well tolerated. There is luckily a very small group with patients that have very, very, very severe involvement of the disease. I think in last year I saw only one patient that had such a severe involvement that I had to use this drug, which is called cyclophosphamide, and cyclophosphamide is chemotherapy. Chemotherapy is usually prescribed to patients that are suffering from cancer, but you can also give this kind of drug to patients with very severe autoimmune disease. But you can understand that this drug, although effective, has many side effects, and we'll try to avoid it as much as possible and try to come out with the drugs that I mentioned in level 1, 2, and 3 on this slide. Now I mentioned biologicals being an effective treatment in patients with Behçet disease, and especially anti-TNF being an effective therapy. But I also mentioned in the pathophysiology part of my presentation that in Behçet's disease, many cytokines are involved. TNF-alpha is one of the cytokines that is involved in Behçet's disease, but it's not the only one. So IL-1, IL-18, IL-6, TNF-alpha interferon, all cytokines that are also involved in Behçet's disease. And like we can block TNF by using anti-TNF, we're also able to block these other cytokines. And in a way, you do so by using colchicine and thalidomide and prednisone and azathioprine. You also have an effect on these cytokines, but you can also directly try to inhibit these cytokines, as you do with anti-TNF, which blocks then the TNF-alpha. But you can also use this is still something about the anti-TNF. One of our patients presenting with the skin involvement, the erythema nodosum. This is before anti-TNF treatment, and when she was on anti-TNF treatment, you saw a dramatic improvement, not only in the skin, by the way, but also of the other manifestations of her Behçet's disease. So Behçet's disease is treating with anti-TNF. If you have sight-threatening uveitis, it's also used for other manifestations. And there is a recommendation, a EULAR guideline on the treatment of Behçet's disease with anti-TNF. And it mentioned that it should be used, or it could be used in severe eye disease, in gastrointestinal tract involvement, in neurologic involvement, but sometimes also in patients with mucocutaneous, so involvement of the ulcerations in the mouth. You can use anti-TNF therapy. And the anti-TNF is, as you can see, quite effective if you have, for instance, as you can see here, CNS involvement, so the neurologic symptom involvement. It's also relatively effective in gastrointestinal tract involvement. It's less effective in oral ulceration and skin involvement, but most patients do have improvement, although not full relief of their symptoms. I was coming to this slide. TNF-alpha blockage is a very effective treatment in many patients with Behçet's disease, but it's not the only biological we can prescribe. There is anti-IL-1, there's anti-IL-17, anti-IL-6, anti-CD20, which is anti-B cell therapy, or anti-CD52, which is a very aggressive therapy. It's hardly ever used anymore, but it's a way to knock out all the T cells, or anti-CD25. All these drugs have been tried in patients with Behçet's disease to lower their disease activity. So, for instance, IL-1 blockade, that's Kineret or canakinumab, has been used in a limited group of patients with Behçet's disease and has been shown to be effective, but it's a very, very, very expensive treatment, especially if you're using canakinumab. So in the Netherlands, I'm not allowed to prescribe canakinumab in patients with Behçet's disease because it's less effective than anti-TNF and it's way more expensive. Ustekinumab is a drug which is often used by dermatologists for other indications. Blocking IL-17 is effective in a limited group of patients. I guess more effective than blocking anti-IL-1, but the same holds true for anti-IL-1 because it's an expensive drug, because it's less effective than anti-TNF as far as we know for now. I'm not allowed to prescribe it, only on very rare conditions. And is there a new kid? Yes, there is a new kid on the block. And this new kid on the block is anti-PDE4. And PDE4, or phosphodiesterase 4, is an enzyme that is located within the cells of the immune system. And PDE4 is involved in activating these immune cells. So PDE4, if it's high, it will lead to more active and therefore not very well, if you look at Behçet's disease, immune cells, because they then start to attack the own body. So if we can, for instance, try to block this PDE4, then in Behçet's disease that might have a positive effect. We know that blocking PDE4 in patients with psoriasis, which is a skin disease, which is also some sort of autoinflammatory disorder, but mainly involving the skin. In psoriasis, this treatment actually is quite effective, and it has been tried also in patients with Behçet's disease. And what you then do with using this drug, which is called apremilast, is that by giving this drug, you block the PDE4, and you will get a lowering of the inflammatory cytokines, which I mentioned earlier, TNF-alpha, very pro-inflammatory cytokine, IL-1, IL-6, very strongly pro-inflammatory. If you can block these pro-inflammatory cytokines, the immune system will get more quiet, and a disease like Behçet's disease, in which the immune system is very active, will become better. Apremilast, as I mentioned, it does work in psoriasis. Does it work in Behçet's disease? Well, it has been tried. There has been a placebo-controlled trial performed, which has been published in the New England Journal of Medicine. And what you can see is that in patients with Behçet's disease that are treated with this new drug, apremilast, they show a significant reduction in disease activity. As you can see, over here, these are the patients that are treated with placebo. You look at the number of ulcers that these patients have. Yes, you see a slight reduction in the number of ulcers, but if you look at the patient group that is treated with apremilast, you see a more pronounced reduction in the number of ulceration. And when the patients that are originally on placebo start on the drug, you see that also they go down in the number of ulcerations. And when you stop the medication, the number of ulcerations in the mouth will go up. So apremilast is a promising drug if you look at ulcerations, but does it also have an effect on joints? Because many patients also complain of arthralgia or even frank arthritis. And this has also been studied, an observational study. And what you saw is that it's not only effective on oral ulceration, but you see also a reduction in joint complaints. So patients have less arthralgia, have less arthritis, so they're doing better. But I also should mention that apremilast is not a drug that is free of side effects. In fact, many patients that we start on apremilast will stop the drug, although it's effective for their ulcerations, although it's effective for their arthritis, but they get nausea and vomiting, and you have to slowly raise the dose in patients with apremilast, because if you start full dose directly from scratch, all patients will stop because of the side effects in this drug. But knowing that new drugs are on their way, like apremilast, which inhibits PDE4, with the cytokine blockers, with the blockers of the T cells and the B cells, although for now Behçet's disease is in many patients a disease which is still hard to treat, and many patients, although on treatment, will have still complaints of their disease. I guess the future also for patients with Behçet's disease will be bright, and if Immunate will lead to discovering new pathogenic mechanisms of Behçet's disease, and thereby by new potential strategies to treat patients, it will become brighter and brighter.